So we have our cuff, okay? And you must know that blood pressure cuffs come in different sizes, okay? A cuff for me, I'm usually like a regular size cuff or normal cuff, is not going to be a cuff that we will use for everybody. If the person has a bigger arm, you know, sometimes we get these bulky guys coming in and, you know, their arms are this big. You cannot put a small cuff or a regular size cuff on somebody if it's not the appropriate size. What will happen if I put a cuff on somebody's arm that's too small? Do you think I'm going to get a blood pressure reading that's too high, falsely high, or will I get a blood pressure reading that's too low, that's falsely low? Too high, because it's going to be too tight on them, and it's going to squeeze their arm even harder than it should be, and it's going to give us a false high reading. That's not a good thing, because if you're the nurse or you're the PCT or you're the CNA and you're taking blood pressure and you go and tell the nurse or you go and tell the doctor, oh, you know what, so-and-so in room whatever, his blood pressure is 140/90. What's going to happen? Well, what we're going to do is we're going to wait a few minutes and we're going to take a blood pressure in the other arm. But if we're giving misinformation to nurses and to doctors, they're going to possibly order blood pressure medication for this patient. So that's how serious this is. We need to make sure we have the right size cuff on our patient, okay? Inversely, if we have a cuff that's too big, Kristen, Professor Gagne, has very tiny arms, and this cuff happens to work for her. But if this cuff was way too big, what's going to happen? What reading am I going to get? Too high or too low? Too low. And the same thing can happen. If her blood pressure comes, you know, it's not coming up normal, it's coming up way too low, they may talk to her about, you know, adding salt to her food, or ask her if she's like symptomatic, you know, does she get dizzy, does she get lightheaded? So we don't want to do that. We can't take this lightly. We have to be very good about our, when we take blood pressures, and choosing the correct size cuff is extremely important, okay? All right, and to know that, whether we're choosing the correct size cuff or not, what I'm going to do is, yes, okay. So on this side, it says range, okay? So when I place this on Professor Gagne's arm, and I close it like this, where it hits, when it's fully around her arm, if it's between this arrow and this one, then I know it's a good size. If I put it around her arm, and I'm wrapping it around, and it's falling, you know, way too, it's outside of these margins, then it's going to be possibly either too big or too small. So please make sure that you're assessing that when you're doing each other's blood pressures. If you need a bigger cuff, we have bigger cuffs. Come to me, I'll get one for you. If you need a smaller cuff, we have those as well. Come to me. I'll be very proud of you guys if you guys realize that you need a bigger cuff or a smaller cuff. That would be very observant. Okay. All right, so how we place the blood pressure cuff, guys, is we want to, well, let's just talk about one other aspect. This is the, say it, sphygmometer. Okay. If you look at your sphygmometer, guys, you'll see numbers on there, right? Tell me, what is the interval of these numbers that are showing? 20, right. We have 20, 40, 60, 80, 100, and so forth. So in between those numbers, there's a very dark line that's a little bit longer than the rest of them, right? What marking do you think that is? By tens, right. So the first dark, longer line between 20 and 40 obviously is 30, correct?
Yeah.
So all those little lines in between those, how much do you think those are? 2. Okay. When we take blood pressures, guys, we don't want to round up to a number. We don't want to round down. You're going to get so good that you're going to be able to pinpoint a number to, you know, to the you know, in 2. So like, what if, I think yesterday I took yours, it was like 116 over 62 or something, okay? You cannot say, oh, your blood pressure's about 120 over 70. You can't round up, you can't round down. It's that important that you get as close as possible. When you guys get good enough, I never even want to hear the word about. Your blood pressure's about, is that accurate, saying the word about or around? No. You're going to get that good that you'll be able to pinpoint it exactly. And what we're going to do after we practice vital signs is going to be a lot of fun. We're going to go into the mannequin. We have a mannequin that gives us blood pressures and vital signs. We'll be able to take vital signs on him. And I'm going to set the mannequin for a certain blood pressure, and you guys are going to get an opportunity to go in, take the blood pressure, and the person who gets closest to, and last year we had one person that was spot on, to the blood pressure that I set the mannequin for, will get like a prize. So it'll be a lot of fun, and that's a good way. And we're also going to follow behind you when you're doing blood pressures on each other. So we'll know if you're close or accurate, but it's going to take time. We don't want you to beat yourselves up about it if you're not getting it right away. It's going to take a little bit of time to get this down, but you're going to be pros, trust me, okay? All right, so the sphygmometer goes on here, it hooks onto here, all right? And you want to have this at your eye level and so that you can read it properly when you're taking the blood pressure. Okay, so we're going to wrap it around Professor Gagne's arm. You want to put it at least 1 inch to 1.5 inches above the antecubital fossa, guys. That's that crook in your elbow. It's called the antecubital fossa. You want to have it above there. And then you want to place this over, it says artery. You see the little arrow that says artery or place? What else does it say on there, Wendy?
I think it says place artery or something.
Artery mark. Okay. So that's going to go over what artery, guys, is there? Brachial, right. So we're going to place it over the brachial artery, which is somewhat on the inner part of your arm. And then we're going to wrap it around and Velcro it together, okay? So now, if you look up, stand up for 1 second. If you look at Professor Gagne's arm, you see where it lies here, where the last of the Velcro lies? It's within that margin of the arrow. You see it? So I know this is a good cut size for her. So ask her to have a seat. Okay. All right, so
Keep listening. We'll practice after we get through it all.
All right, so before I even place this cuff, though, you want to assess the patient's arm and you want to ask the patient some questions. Very, very important questions, okay? It can harm a patient. You can bring harm to a patient if there's something going on with this arm that we don't know about, and so we have to be careful in choosing the correct arm to do a blood pressure on. We want to ask our patient, first of all, let me take it off. All right, Professor Gagne, have you had any mastectomies or lymph node removal?
No.
Okay, what's a mastectomy, guys? Okay, mastectomy is breast tissue removal, right?
Correct.
And a lot of times when they take, do a mastectomy, they also do lymph node removal because they test the lymph nodes to see if the cancer spread into the lymph nodes. Okay, what happens is that why we don't want to put a blood pressure cuff on that side is because you don't have lymph nodes that can readily transport that lymph out of that area. One of our professors, and I know she won't mind me saying this to you, she's very open about it, had a double mastectomy and lymph node removal, and she's doing great. She battled cancer, she won, and she's doing fantastic. But every now and then she gets lymphedema, and she'll get a lot of swelling in this area, in the axillary area, in the breast tissue area. If you're shaking your head, you know what I'm talking about. So she cannot do, now she's had double, so I don't know how that works with her, but for anybody who's had one-sided mastectomy, we do not want to put something on the arm that's going to, cause possible issues with the circulation in that arm, okay? So that's one of the reasons we don't put a blood pressure cuff on that arm. The other reason we don't want to is, how many of you know what dialysis is? Okay, dialysis is what? It's a machine. We hook the patient up to a machine that does the work of the kidneys. If the patient is in kidney failure and the kidney's not able to filter the blood and clean the blood, they have to get dialysis, usually 3 to 4 times a week. It's a machine that hooks up to what's called a shunt on their arm or fistula or something, and that's a little port, so to speak, that's under the skin. That's another reason we cannot put a blood pressure cuff on that particular arm if they have that. So I've got to ask Professor Gagne. Do you have a shunt or fistula? Do you receive dialysis?
No.
Okay. So we want to make sure that's clear, all right? This is very important, guys. And you guys, you may not become nurses right away. You may become, a lot of our students become CNAs or PCTs, and you'll be doing that on a regular basis. So you have to ask your patients, all these questions. So it makes, it's that important, okay? All right. Then we're going to look at the arm. I'm going to look and make sure there's no excessive bruising, okay, ecchymosis, no redness, erythema. We're going to look to make sure there's no edema. What's edema? Swelling, okay? A lot of our patients have CHF, okay? They have heart failure. What happens with heart failure? Right-sided heart failure. We have peripheral swelling, right? We don't want to put a blood pressure cuff and squeeze an arm that's already swollen, right? That can cause harm to the patient, all right? and any other reason. If the patient has skin breakdown can be like a rash, it can be excoriation, it can be, some patients older patients get skin tears, anything like that, we don't want to put a cuff on that arm, okay? Professor Gagne is quite healthy. Her arms are great. I don't see any reason visually why I can't put the cuff on this arm, but I'm going to ask her anyway, okay? So what you guys are going to do is you're going to take the pressure in the one arm, and then a couple minutes later, you're going to take it again in the other arm, okay? And you're going to, just to give you an idea if you're doing it the correct way, if you're getting around, they're not going to be totally the same reading, okay? All right. So with that said, is there any other reason? Oh, another reason why you wouldn't want to put a blood pressure cuff on the arm is if they have an IV. Does everybody know what an IV is? Intravenous access on that side. You definitely want to go to the other arm to take blood pressures. If they're in hospital, most likely they will have an IV, okay? And you don't want to do it on that side. Same reason. You're already pumping fluids into this arm. Why would we want to start squeezing this arm? We can cause trauma or cause harm, okay? All right, so let's put this back on her arm again. I'm going to line up the arrow with her brachial artery. I'm Velcroing it, guys. I'm not making it terribly tight, and it's not terribly loose either. You should be able to get a finger's width under there, just like that, okay? And if it's too tight, trust me, they'll tell you. Okay. And then we're gonna hook this up on here, and it's gonna be in my sight. The arm itself, you want the arm to be at the patient's heart level, okay? It gives you a more accurate reading to do that.
Chair down. You want the feet flat on the floor.
Yes.
I can get my chair down.
We have to instruct the patient to sit appropriately. We want her back up against the chair, supported by the chair. We want her feet flat on the ground. A lot of times you're going to have your patients in medical tables, exam tables like that. That's not really possible. Most of the time they're coming in for a physical, they're just getting a checkup. If it was a true cardiac patient that we needed to get a very solid blood pressure reading from, we're going to make sure that they're sitting the appropriate way and supported the appropriate way, because we don't want our readings to be skewed. Yes?
I have a question. So in the instructions, it was saying that we shouldn't talk to them for about 5 minutes, but in a real setting, we're asking questions as we're going along. So how? Yeah,
the reason for that, say I'm running to the doctor's office, I'm running late, the bus was late, you know how tough they are with appointments, you're 5 minutes late, they tell you to go home. Well, I'm running, I sit down in the chair, I'm like, I'm so sorry I'm late, I just got here, I get my kids, something happened with the kids, and da-da-da. Okay, what's gonna happen if they take my blood pressure right away? It's gonna be way high, because I'm already stressed out, I'm already nervous. So what they want you to do is just sit. I've had, professors come in and say, I have this tremendous headache, which is a very solid sign of a high blood pressure. And I'll say to them, okay, but I'm gonna take your blood pressure, but sit here for 5 minutes, and I'll walk away and I'll do something else. You have to let them sit, because it's just gonna calm them down a little bit. We already get what's called white coat syndrome. It's a real thing. They already get nervous about being at the doctor's office, especially if they're sick, something's going on, okay? So have them sit for 5 minutes. Don't talk to them. The question asking can cause anxiety. So that's why we suggest just let them sit, leave the room, and then come back and say, okay, I'm here to take your blood pressure. So that's what that was about. Okay? So I'm looking, I want to make sure Professor Gagne's feet are flat on the floor, they're uncrossed. Ladies love to cross their legs. I love to cross my legs. It's not that great when you get older. I have varicose veins, I gotta watch out for clots and stuff. Make sure your partner, make sure your patients are not crossing their legs. A lot of your patients are going to be in bed. Same thing. They love to cross their legs in bed. Make sure their legs are not crossing in bed. Okay? All right. So with that said, now I'm going to take her blood pressure. I want her arm to be comfortable. I don't want Professor Gagne's arm being held up by itself. I'm not going to say, okay, hold your arm up for me. I'm going to take your blood pressure and have her hold it there. That's going to probably skew my reading as well. Plus, it's uncomfortable to her. Why should she have to hold her arm up? Okay? We want her arm to be resting on the table, and we want her to be relaxed. All right? Okay. So, sometimes, again, we'll have the patients in the medical table, right? And you'll see doctors do this. How many of you have seen the doctor do this before? They support the arm under here. You thought they were crazy, right? They're like, what are you doing? No, it's because there's no table, and there's no way to, have her arm at heart level other than me holding it up there, okay? And that's good doctors, good nurse practitioners and good nurses. They'll do it the correct way. All right, so with that said, okay,
Tangled.
All right, so I'm going to make sure that I can look at my sphygmometer and read it correctly. All right. Before we even get started, I want you to take a look at this, guys. Right-handed people, you're going to hold this bulb in your right hand, okay, and use your 2 fingers to toggle this. Turning it toward, so to speak, if you're looking at this way, to the right, or turning it away from you if you're holding it like this, is going to close it, and it's gonna allow me to pump this up without air escaping. Okay, so here, this is what it's gonna sound like if it's open. You notice that the sphygmometer is not pumping up. You hear that air?
You can hear the air leaking.
Yes.
With every pump.
It's not closed properly. So if you start pumping up your blood pressure on your partner and it's not going anywhere, it's probably because it's not turned the correct way. So for righties, you're going to turn it away from you or to the right if you're looking at it like this, okay? And what you want to do is you're going to turn it until it doesn't go anymore. Don't over tighten it, because what we want to do is we want to pump it up, and then we just want to go back a little bit and just open it up very slowly so that our reading starts to go down ever so slowly so we can accurately read it, okay? We're not going to pump it up and then open this up really wide because it's just going to go, okay? So be careful when you're doing that. So I would close it, and it's just touching. I can feel it, it's closed. It won't go any further, but I'm not over tightening, because if I over tighten and I start to back out, it's going to go really fast, okay? All right, so. Okay. That's another thing, you don't want to leave it on too long. I didn't even pump it up, girl. Okay, so the first thing you want to do, this thing is like, there we go. Okay, the first thing I want to do is I'm going to put my 2 fingers on her radial artery, okay? Where's the radial artery located, guys? Remember from A and P? It's along the radius, or along the thumb. So you're going to put your 2 fingers, you can practice on yourselves right now.
Find your pulse.
Find, what I like to do is along the thumb, right here, there's like a little spongy part. If you press there with your 2 fingers and then kind of press up against the bone, you can't miss it. You really can't miss it. You never want to press with your thumb. What happens if you press with your thumb? Why not? You have your own pulse in your thumb. You don't want to do that. So you're going to just gently take your 2 fingers, feel your own. Can y'all feel it? Mm-hmm. Okay. We'll get into pulse next week. We're not going to talk about that today. But for our exercise, we're gonna do this. Okay. So what I'm going to do is I'm going to press my 2 fingers on Professor Gagne's radial pulse, and then I'm going to pump up my sphygmometer. Now, when I pump this up, I'm feeling for the pulse. When I don't feel the pulse anymore as I'm pumping up, I like to pump and then feel, pump and feel. If I don't feel this anymore, I'm going to look at my reading at that point, and I'm going to add 30 to that. Okay, so let's pump it up and I'll tell you what I get. Okay, it stopped around 120. Why do we want to do this? When I take her blood pressure in a minute, I'm going to add 30 to it, so I'm going to pump it up to 150. I'm not going to go any higher. Why do we do this little exercise? Say again?
So you can make sure that you're completely occluding the artery?
Well, no. Good try.
Yeah.
Good guess. Why, okay, so what did she just say to me before I even started? What did she say?
Sis,
My arm is going numb. A little theatrics here. We don't want to pump it up any higher. How many of you go into Publix and take your blood pressure in Publix? I do. I make sure I like it.
One. I got you.
Oh, guys, you don't do that? I do. Every once in a while, I just slip my arm in there. What happens when you do it? Or at the pharmacy. What happens when you do use one of those machines to take your blood pressure?
You're too tight.
It hurts. It squeezes way too tight, okay? Your patients that have cancer, your patients that have fibromyalgia, your elderly patients that have no muscle mass on them, it's gonna hurt if we over pump that blood pressure cup, okay? So this is just a little trick we do to make sure that I don't over pump and squeeze too hard. Again, we don't want to cause harm to our patient. We don't want to cause pain to our patient, all right? So it stopped at 120. So now when I'm ready to take her blood pressure, I'm going to pump it up to 150, okay? I'm gonna pump it up. I'm gonna make sure my toggle's to the right or turned away from me because I'm righty. Lefty, you're going to turn it toward you. And I'm going to pump it up to 150. I'm gonna back off slowly. Now, when I back off, I may not hear anything right away, but all of a sudden I'm gonna start to hear a heartbeat, okay? And this is where you have to really, really listen. I'm gonna hear boom, 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 just like a standard heartbeat. That first beat that you hear is our systolic number. 120 over 80. 120 is the systolic reading. 80 is the diastolic reading, okay? The first beep, boom, boom, I hear. First, like I said, you're probably not gonna hear anything initially, and all of a sudden, maybe around 116 or wherever, I'm gonna start hearing boom, 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 and it's gonna keep going. Boom, 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 boom. It may get a little fainter. This is where you have to really listen. Eventually, you're not gonna hear it at all. That point where you stop hearing it at all, that becomes your what? That's your diastolic number, okay? So the first the first heartbeat you hear is your systolic. The second, when you don't hear it anymore, when you stop hearing it, that's your diastolic. A lot of students make the mistake of stopping too soon because they're like, oh, I think I heard it. If you're not sure, do not guess. Do not guess your patient's blood pressure. It's the worst thing you can do. If you're not sure, pump it up again. And do it again. You guys are going to practice this a lot. You're going to become pros, trust me. That's why we want you to switch around to other people too. Because say Wendy keeps taking Faith's blood pressure. She's going to know Faith's blood pressure over time, or roughly where it's at, right?
True.
But she won't know Kenzie's blood pressure. So that's why we're going to switch around and do various people, okay? All right, so let me take a blood pressure and then we'll talk about our readings following the blood pressure. Okay.
Oh, it's so good.
Am I doing it the right way? Am I doing it the right way? See who's sleeping and who's not. Okay, putting them in, facing away from me. Okay. You can, if you're not sure, like when, if this is turned correctly, if I tap on this very gently, you don't want to blow out your ears, you should be able to hear that inside, okay? If I have it turned the other way to where it's open for the valve, and I tap it, I can tap this all I want, I can't hear it, okay? So I'm going to turn this and make sure it's open, all right? What I want to do,
Your ears.
we're going to go the
Flip
other
your
way.
ears. There you go. There you go.
Okay.
Now
So I'm going to place this over this area in the antecubital fossa, and I'm going to pump up my blood pressure cuff, and I'm going to listen for that first heartbeat, and then I'm going to let it go down until I can't hear anymore.
I'm sure at this point I have no blood flow. So numb.
That's so good. It's probably just from being elevated.
Yeah, exactly what it is.
Okay. All right, ready? Here we go. Shh. Nice to be quiet. Pumping it up to 150. Now I'm backing off very slowly. Okay. I'm really good. I got 116 over 58. Okay. So 116 is a very good reading. What is the American Heart Association's recommendation for blood pressure now?
It's on your table.
120 over 80.
No,
It's on your table. What does it say for normal?
Oh.
Exactly.
Less
less
than
120 over 80, okay? Doctors love blood pressures less than 120 over 80, okay? Her top number, her systolic number, 116, that's great. Her diastolic number at 58 is a little low, okay? When the patient has low blood pressure, like I said, doctors, nurse practitioners, they love it because high blood pressure is certainly so much worse than low blood pressure, because what can happen with excessive high blood pressure that's not treated? Stroke, heart attack, a whole bunch of issues, okay, we're not going to talk about right now. All right, so with her low blood pressure though, we have to talk to her as well, because as the nurse, low blood pressure can be an issue too. How many of you have low blood pressure? Okay, have any of you ever had symptoms with low blood pressure? Dizziness, what else?
Especially when you stand
When you stand up, right? When I was 14, going through, getting my period for the first time, menstruating, and around that time of the month, especially, and I had extremely low blood pressure. I would jump up out of bed and I would hit the floor and I would pass out. Yes, my mom used to find me on the floor passed out because my blood pressure was so low, and then losing so much iron with my period, losing all that blood. So it's low blood pressure is generally not a problem, but it can be a problem if the patient is symptomatic, because then we have to educate them, all right? So I will ask Professor Gagne, your blood pressure is great, but the diastolic number is a little bit low. Do you have any issues, like do you get lightheaded, especially standing up too quickly? Do you get dizzy at all?
No.
Okay, so she doesn't have any symptoms. She's asymptomatic, so that's fine. She's good. She's good to go. The doctor used to tell me, put salt in my food. When my blood pressure can be like 90 over 48. Seriously, it can be very low. He'll say, put salt. What happens when you put salt on your food and you intake salt? Water follows salt, right? So I will retain water and my blood pressure will go up, right? So they used to advise me to do that. We don't advise everybody to do that, just so, you know, when people's blood pressures are a little bit low.
What is the term when you're sitting or lying and then you get up and the blood pressure comes down when you're sitting or lying? What's the term for that? Good.
Yes, orthostatic hypotension, right? Hypertension means high blood pressure. Orthostatic hypotension is getting into a seated position and then standing and getting into a standing position, and any of those positions the patient starts to feel dizzy, weak. Why is this important, guys? As nurses, as CNAs, why, as nurse practitioners, why is this important? What happens when your patient falls in the hospital? They hurt themselves, right? What else happens? What happens to the nurse? He or she gets in trouble.
It's all about us.
It's all about us. Our patient gets hurt, which we feel terribly bad about, but we also have to fill out an incident report. It's called a sentinel event, and we get written up, we get in trouble, we get spoken to, okay? So we have to prevent falls, and one of the ways that we prevent falls is by educating our patients and telling them about low blood pressure and the dangers of low blood pressure. So now you're learning something new today, right? It's not just high blood pressure we have to worry about. We have to also worry about low blood pressure. So Professor Gagne is good. Her blood pressure is where we want it. She's asymptomatic. She doesn't have any issues with it. So that's it. Okay. Any questions, guys?
Yes.
So every time you take a blood pressure, you want to do where you feel the radial artery and then see when it stops and then go back and take the blood pressure?
While we're in here, yes.
Yes. Okay.
Yes.
But in like a patient setting?
No, in a patient setting, realistically, Good afternoon, Ms. Gagne. How are you today?
I'm fine. How are you?
I'm good, thank you. My name is Christine. I'm a nurse here, and I'm here to take your blood pressure. Before we get started, do you have any questions for me?
No.
Okay. All right. So I'm going to take your blood pressure. Before I do get started, I want to make sure that you are sitting appropriately. So if you can sit back and sit nice and tall. Put your back against the back of the chair. Uncross your legs if they're crossed, and have your feet flat on the ground. Very good. Okay, I am going to take the blood pressure on this arm, if that's okay with you. Any reason why? Is this arm okay for you?
Yes.
Okay, so let me just ask you a couple of questions. Have you had a mastectomy, like breast tissue removal or lymph node removal on this side?
No.
Okay, I don't see any fistula or shunt, any dialysis?
No.
Okay, very good. And I don't see any edema or redness or skin breakdown. Okay, so we'll get started with this arm. Okay. First thing I'm going to do is place this on your arm. I'm using the appropriate sized cuff. Okay. Thank you for holding that up for me. Okay, it's a good size for you. We don't want the cuff to be too big or too small because that could skew our results. Okay. Okay, the first thing I'm going to do is pump this up to get a baseline of where I'm going to pump it up when I actually do take the pressure. So bear with me for one moment. Okay, I stopped feeling it around 140, so I'm going to pump it up to 170. You doing okay?
Yes.
Did that hurt too much?
No.
Okay, good. Okay. The blood pressure was 95 over 62. Is that around normal range for you?
Yes.
Okay,
It's only
good.
a little low.
Okay, that's very good because normal standards now are, we like it to be below 120 over 80, so it's good. But we are going to retake your blood pressure in the other arm just to make sure in a couple minutes. Okay? All right,
Great,
very
thank
good.
you.
Thank you. The doctor should be in shortly.
Thank you.
You're welcome. Nice to meet you.
You too.
Hi, Miss Bunny. Good morning. How are you?
I'm good. How are you?
I'm very well, thank you. My name is Christine. I'm a nurse here at Palm Beach Atlantic Hospital, and I'm here to take your blood pressure.
Okay.
Okay, any questions before I get started?
No, ma'am.
Okay, awesome. I'm going to just close the door to give us some privacy, and I'm going to wash my hands, okay? May I see your ID bracelet?
Sure.
Thank you. And what is your name?
Kristen Gagne,
Okay, date of birth?
November 27th, 1996.
Okay, and what brings you to the hospital while you're here?
Had an appendectomy.
Oh, okay. How are you feeling? How's the pain?
It's very good right now.
Okay, good. All right. So I'm going to get started. Before I do, I just want to make sure you're sitting up nice and tall and in the bed there. And also, have you had anything to drink, caffeine products or anything, or have you smoked anything in the last half hour? I know it's the hospital. You're not supposed to smoke here, but I have to ask.
No.
Okay, very good. All right, so I'm going to get started. If it's okay with you, I'm going to use this arm. Let me take a look at it, please. Okay, I'm just looking at your arm. Have you had a mastectomy on this side, which is any breast tissue removal or
No.
lymph node removal?
No.
Okay. All right, very good. I don't see a shunt or fistula, and you don't have any dialysis. You're not getting dialysis?
No.
Okay, very good. And there's no swelling in this arm. There's no edema. And I don't see any redness or skin breakdown. Okay, very good. So we'll get started. If
Okay.
that's okay. And is this arm okay to start
Yes.
with? Okay, very good. All right, I'm going to put this cup on your arm. It seems to be the appropriate size for you. Okay. Thank you. Pulling that up for me. Okay, very good. Thank you so much. Okay. Before I get started, I'm just going to get a baseline of where I'm going to pump it up when I actually do take your blood pressure. Okay, I stopped feeling your heartbeat at 140, so I'm going to pump this up to 170. Okay. Blood pressure is 108 over 60, which is wonderful. It's below normal range, which is 120 over 80. So
Okay, great.
awesome. Is that where your blood pressure usually is?
Yes.
Okay, very good.
Thank you.
You're so welcome. Okay, I'll be back to check on you in a little bit, and the doctor should be.
Frog in my throat that whole time.
That's a wrap.
Don't you teach them to say, is there, like if you say, have you had this, this, or this, and they say no? Right.
But that's the past. This is the future. Moving forward. Okay, are we being recorded right now?
Yes.
Okay.
Oh my gosh. Okay.
Are you ready?
Go.
Okay.